Good afternoon, everyone. We're going to give everyone a couple minutes to just get into the webinar and then we'll get started. Good afternoon. I'm Chirag Shah. I'm the co-director of the breast program at the Cleveland Clinic and director of breast radiation oncology. It's my pleasure to introduce my partner in crime for this great debate, Dr. William Small, professor and chairman of the Department of Radiation Oncology at Loyola University and a world-regarded breast cancer expert. Today's topic will be IORT and breast cancer, the great debate. And Dr. Small has kindly agreed to let me go first. So I'll start off the debate and then subsequently we'll let Dr. Small, and then we'll save some time at the end for some questions and answers. So I'll be presenting the case against IORT in the management of early stage breast cancer. In terms of radiation therapy in early stage breast cancer, when we look at breast conserving therapy, what we've seen time and time again is that it provides equivalent local control and survival as compared to mastectomy, with increased rates of local recurrence and breast cancer mortality with the omission of radiation. Importantly, almost all of this data is predicated upon radiation being given with whole breast radiation for 5 to 6 weeks. And in 2022, I think for most people, we would say that's probably not what we actually do in real practice. And when we look at the evolution of breast radiation, we think about both whole breast irradiation and partial breast irradiation. And with respect to whole breast radiation, as I mentioned, this is what was used in the trials comparing breast conservation to mastectomy. And we've evolved from standard fractionation to hypofractionation with the OCOG and START trials to ultra short radiation with FAST and FAST forward, though that's an evolving area of study. With respect to partial breast irradiation, individuals like Dr. Polgar and the Hungarian group with the interstitial brachytherapy and subsequent Jack-Estro trials, as well as applicator brachytherapy, have defined the role of brachytherapy and the role of partial breast irradiation, while external beam techniques, including 3D conformal radiation, IMRT, and protons, have all been studied in randomized phase 3 trials, with the exception of protons being studied in individual institutional studies. So the questions that have emerged in 2022 are, can we use shorter regimens, whether they be whole breast or partial breast? And I think the answer is absolutely yes. Can we use partial breast approaches? Again, I think the answer is absolutely yes, whether it be brachytherapy, external beam. Is IORT the right approach? My job today is to convince you that the answer is no. When we think about IORT, I think it's important to recognize that IORT is not a monolith. It's really a combination of different techniques. And really 2 techniques we think about are electron or Elliott and low energy, which could be target, or other forms of low energy IORT such as ZOFT. In terms of low energy, which is typically around 50 kV, we prescribe to the surface, and at 1 centimeter, that's 5 to 6 gray, which is much lower than most other APBI techniques give at 1 centimeter or even 2 centimeters. And so one comment I always make is, do we know any other disease other than lymphoma where this type of dose is effective? In terms of electrons, we use various energies which allow for greater depth at dose, but often at the risk of fat necrosis based on data from the Elliott trial initial analysis. With regards to both techniques, we often have limited image guidance and limited dosimetry, though both can be used in certain situations. But we really want to know in 2022 where our dose is going. With regards to data, we'll start with the electron IORT patients. And really, there's a couple papers that really stand out. And the first is the Elliott trial, which was a randomized trial of about 1,300 women. It was designed as an equivalence trial. And there was really limited additional whole breast irradiation given in this trial. There was data recently published in Lancet Oncology with updated outcomes demonstrated at 10 and 15 years, the rates of local recurrence were 8.1 and 12.6% respectively with IORT, as compared to 1.1 and 2.4% with whole breast. So these are pretty drastic differences. I tell people as a good comparator, I always think about B39, which had right around a 3.5% rate of recurrence at 10 years. So if we look at it compared to that, this is a really increased rate of recurrence. Unfortunately, this study didn't collect long-term toxicity data, so we can't really comment on that with electron IORT versus whole breast. But this is the Kaplan-Meier curve showing really the continuing divergence of local recurrence between the two options. This was a nice paper that actually just came out. It's still in published but not printed form from the Red Journal, which really compared electron IORT to external beam partial breast, which there's not a lot of data comparing IORT to partial breast. This was about 600 patients, looking at patients 60 years or older, small tumors, N0, and a pretty good follow-up, about 5 years. And what they saw was that even though there was a higher risk of patients in the partial breast with increased positive margins, that the local recurrence rate was about 10.6% with IORT as compared to 3.7% with partial breast. So even when you're stacking the deck against non-IORT options, IORT is still showing higher rates of recurrence. And so this, for me, shows that when you combine all this together, the electron IORT is clearly not the answer. Let's transition to low energy IORT. And really the big study in this area is target A in particular. This was a randomized trial of 3,400 plus patients with a non-inferiority design and a 2.5% non-inferiority margin. IORT with 15% of patients receiving whole breast. Importantly, this was split up, about 22% in the pre-pathology group where IORT was delivered before final pathology was available, as compared to only 4% in the post-pathology stratum where it was a second procedure. The initial outcomes were published at 5 years with a median follow-up of 2 years, 5 months. This in itself raises some questions. I think if we think about most breast trials, if you present 5-year data, you want median 5-year follow-up or greater, which you can see from the previous studies. But in this case, we still presented 5-year outcomes with only 2.5-year follow-up. And what we saw was that the local recurrence overall was increased with IORT, but within the non-inferiority threshold of 2.5%. It was above the non-inferiority threshold for the post-pathology cohort, 5.4 versus 1.7, but well within for the pre-pathology, 2.1 versus 1.1. In the last 2 years, we've seen updated data from this trial, but there's a couple comments. One, the entire trial wasn't presented, and this has obviously raised a lot of red flags. Instead of discussing both the pre and post together, both were published separately. Interestingly also, no local recurrence rates were provided beyond 5 years, only local recurrence-free survival. And this, again, I always ask people, do we know any other breast radiation study when you're comparing breast techniques where you don't present local control? So it's very odd. In terms of the post-pathology group, 3.96% versus 1.05% exceeding the non-inferiority, kind of suggesting this isn't the way to go. In terms of the pre-pathology, all we know is what happened at 5 years. And so we saw about a 1.2% difference in local recurrence at 5 years. But if you look at table 3 from this paper, it starts to raise some questions because the overall numbers of local recurrence start diverging. And it's about 60 with IORT versus 24. The other issue is that about 21% of these patients received whole breast. And we don't have any local recurrence rates for those who received IORT alone. Some of the investigators have said this is because this is risk stratification. But the problem is that there was no consistent risk stratification. We let centers pick their own criteria for risk stratification. So how do we know this approach works? Because if we're risk stratifying to use whole breast irradiation in these patients, the low risk group should receive IORT only. But we can't tell people what the rate of recurrence with IORT only is in the pre-pathology cohort. And the biggest question, as I mentioned, is why not present the entire group? And this is from Dr. Kuzik, who was the former chairman of the Data Monitoring Committee for Target A, which says, another common and well-known danger is to focus attention on the most favorable subgroup. The protocol clearly states that the primary analysis should include all randomized patients. So my comments are always, can you think of a breast radiation trial where the final outcomes did not include the whole study? Is it possible that the entire IORT group exceeded non-inferiority, which is why the investigators failed to present the entire trial? Another issue is why there's no local recurrence rates beyond 5 years, only local recurrence-free survival. As I mentioned, there's about a 2.5-fold increase in local recurrence events between the two groups. And all other studies looking at similar types of designs all presented local recurrence rates. While the authors of the study have mentioned steep criteria, which recommend the use of local recurrence-free survival, you can certainly present both local recurrence-free survival and local recurrence without any issues. The other statistical issue with this study is that the 2.5% non-inferiority margin is felt to be too large. This isn't from me, but this is from Dr. Benson and Dr. Havland, who are two experts in this area, who've said, in conclusion, the tumor outcome in the pre-pathology stratum of the Target A trial is consistent with the outcome of after IORT in the post-pathology setting. both strata support the hypothesis that IORT has no clinically meaningful effect on local regional occurrence after surgery. So as I move forward, I want to dispel some common myths about Target A. First of all, one of them is that the largest number of patients evaluating a partial breast approach. There was 3,451 patients, which is a very large study, but it wasn't actually published long-term with that patients. It was only presented in two arms, 2,298 and 1,153, as in comparison, B39 had 4,216 patients. In terms of follow-up, the pre-path had about 9 years and the median for post-path was 9 years, but actually B39 had 10.2 years of follow-up and RAPID 8.6. As I previously mentioned, Target used risk-stratified external beam as a justification for not presenting IORT-only rates, but there was no standardized criteria. And so the question is, why not present those rates long-term with and without if they're truly risk-stratified? The other question we commonly hear is IORT makes sense versus 3 to 5 weeks of external beam. And my question is, would you really say that if a patient felt that they were getting an inferior outcome? And what about 5 days? Because I think that's really the calculus. In patients who we consider IORT in, we can certainly consider 5-fraction whole breast or partial breast. One of the other issues that we realize is that anesthesia time increases drastically with IORT by almost an hour. Even if you use the smallest applicator for low energy IORT, it still takes about 18 to 19 minutes to deliver the treatment and about 45 minutes to an hour to actually get everything set up. With regards to cost, some studies have suggested IORT are cost effective compared to other radiation techniques, but when you account for recurrences, we've done studies showing that actually the cost is not really a big cost savings. Finally, there's been some papers talking about the RBE of low kilovoltage IORT such that the 20 gray 1 centimeter is closer to 50 gray. And this has certainly been modeled in radiobiologic experiments, but I don't know if we have any clinical data supporting that, particularly given these higher rates of local recurrence. And with most partial breast techniques outside of IORT going to 2 centimeters or more. In terms of the failures of Target A, I think this is a teaching lesson for investigators on what not to do with a randomized trial. And some comments are, you always should provide all data, not just favorable subsets per Dr. Kuzik. You should provide transparency long-term in terms of providing long-term local outcomes and providing data for all of the patients. And really, when you look at the responses from some of the investigators at Target A, it's really to not be defensive when responding to critiques of the study, but really try to use them as a way to improve what we're presenting with regards to the data. In terms of modeling Target A, this was from Matt Ward and myself and some colleagues looking at the data that's been published and trying to model out what the rates really are long-term. This was just for the pre-pathology group, so the more favorable cohort, not even including post-pathology. And what we see is at 10 years, the rate of local occurrence is around 1.7% with external beam and around 5.5% with Target, about 6.6% with Target alone, given that 21% received both Target and whole breast in this group. Target R is another nice study. This was presented by Stephanie Valente, one of my colleagues. Multi-institutional retrospective registry real-world data, about 667 patients with 5-year data. Again, showing a local recurrence rate of around 6.6% and 8% with IORT only. And the big difference there is that endocrine therapy really was associated with recurrence. And I think that's one of the things we worry about long-term is as endocrine therapy ends at 5 years for some patients, we may see higher rates of recurrence as things go on. This was just published in the Annals of Surgical Oncology, a slightly different technique than Target, but this was Dr. Silverstein's work looking at almost 1,400 patients with low energy IORT. Local recurrences were 60 with IORT only already, and 41 in the same quadrant. Again, mirroring Target R, about a 6% rate of local recurrence with IORT alone. In terms of the guidelines, both the ASTRO and the ABS guidelines really comment that if you want equivalent local control, IORT is not the answer. This is the ABS guideline talking about both low energy and electron should not be offered. And with respect to the ASTRO guideline, saying that really if patients want cancer control equivalent to whole breast, they should really be counseled about higher rates of local recurrence. Importantly, these guidelines all came out before the updates from both Target and Elliott. But also, just as importantly, both of these panels had folks that used IORT. So I think one of the concerns people have is, are IORT users really involved in these studies, these guidelines? And the answer is they absolutely are included in both. And this is from the ABS guidelines showing that intraoperative radiation is given a weak recommendation as compared to multi-catheter, IMRT applicator, 3D conformal. In terms of alternatives, there are plenty of alternatives in terms of options for patients. Granted, there is nothing at this time that's got level 1 data that compares to single fraction IORT. I do think that's important to recognize. All these other options require at a minimum 5 to 6 extra visits. This is from the Florence trial looking at 5-fraction partial breast, 520 patients, 10-year data. no difference in recurrence with reduced side effects with 5-fraction partial breast. In terms of patients who may not be great candidates for partial breast or unable to get partial breast, FAST and FAST Forward offer the options of 5-fraction whole breast. FAST was not powered to really look at local control, but did look at long-term toxicity outcomes, 900 patients, and at 10 years, no difference in normal tissue effects with 28.5 given once a week as compared to 50 and 25. The local recurrence rates in 900 patients were so low that there were only 11 failures in all 3 arms combined. So overall, it seems to be an appropriate regimen, but one not powered to look at local control. In contrast, Fast Forward, powered to look at local control, randomized 4,100 patients in non-inferiority design, however, only 5-year data, no difference in local control, and a suggestion that these extreme hypofractionation be associated with less risk of recurrence. The one concern I have with Fast Forward is that I don't know how a 1 grade difference over 5 fractions translates into such a big difference in moderate and marked normal tissue effects. I think that's something we're going to have to wait and see on at 10 years. Importantly, most studies that have looked at 5-year hypofractionation data have not shown any difference at 10 years with respect to moderate hypofractionation. So my guess is we'll probably see no difference in this at 10 years based on previous data, but the dose per fraction with these is much higher than that seen with moderate hypofractionation. This is just a study of trials looked at comparing partial breast to whole breast and really showing, unlike IORT, that these studies have not shown an increase in local recurrence as compared to whole breast, which still remains the gold standard. The last thing is the survival question is, if there's no survival difference, why do we care about local recurrence? And I think it's really hard to use that argument in IORT because based on the EBCTG1, we'll need 15 or year greater follow-up, and we'll need a huge number of patients. So even if we add Elliott and Target together, I don't think that's enough patients to see the difference we saw in the EBCTG trials looking at breast conservation plus or minus radiation. Just as importantly, local recurrences matter. They can impact breast cancer mortality, as I previously mentioned. They require additional treatment, and they have a psychosocial impact. And as we said, these recurrences actually increase the cost of therapies overall. So we're not really providing a value when we do IORT if we account for the recurrences and the costs associated. With regards to the Cleveland Clinic experience, we were actually a very high volume IORT center just probably 5 to 6 years ago. We really used a lot of Target, on a fair number of our early stage patients. But over the past 5 years, we've evolved and really preferred approach is 5-fraction partial breast. It includes 6 visits, including SIM to complete treatment. We don't have concerns about inferior local control. There's no extra anesthesia time, and there's no need to await pathology for additional whole breast. And at this time, we rarely use IORT as monotherapy. That being said, we do consider it in patients who will need a boost, particularly for those undergoing oncoplastic surgery. We may use this as a boost technique, and we do have Target B open as a way to look at this, as a way to deliver a tumor bed boost. So in conclusion, the case against IORT is clear, worse left local control with methodologic concerns, and really strong alternatives. So I think we can do better than IORT for our patients. At this time, I'll turn it over to Dr. Small.
Well, thanks, Chirag. Thank you for the introduction. I'll now talk about why Chirag is wrong. If I could find my presentation, here we go. There we go. So thank you. Thanks again for asking me to join this. This is a wonderful thing. I've been doing IORT since about 2010 at 2 different institutions. Took a little bit of why it's a preferred accelerator breast treatment option. I had done a couple talks for Carl Zeiss. That is a disclosure. I stopped doing it in 2020 just to keep this a little bit cleaner. So some objectives. I'll review briefly. Chirag already gave the data, Dr. Shah, about the IOERT, or intraoperative electron radiation therapy. I'm going to review some of the rationale for immediate IORT booster definitive, review the level 1 evidence that we talked about a little bit on Target A, review some retrospective trials, other prospective trials, and some future directions. Because I think there's some really interesting things we can do with IORT. I think it has some interesting biology. So I'm going to limit it a lot. I'm going to talk a lot about the Target trial because that's where the best data is, I think. But electron beam from a linear accelerator is interop, and that's IOERT with a Mobitron, which we've discussed. You can certainly do HDR or even LDR theoretically, but really it's IOERT or 50 kV photon radiation, either the Zeiss Interbeam or ZOFT are the 2 main ways of doing that. So there are a lot of biological advantages of intraoperative radiation therapy. You deliver the tumoricidal radiation dose in a fraction. You can deliver a biologically higher dose, not possible by conventional post-op radiotherapy. And I've been doing IORT and other sites since the 90s. You give high relative biological effectiveness, avoid delay of radiation, theoretically eliminating tumor cell in a fraction population, tumor bed devascularization. This is what I think is kind of cool. And there's a trial we're hoping to do. I'll talk about the systemic effect of a high dose of single fraction of radiation, and really more precise delineation of areas of high risk for recurrence. Dr. Shah kind of mentioned that when it comes to boost, especially with oncoplastic techniques. So IORT electron therapy, I won't do this because you just saw these slides, so I'll try to go through these fairly quickly. This is the updated intraoperative radiation for early breast cancer, the Elliott long-term recurrence and survival outcomes from a single center randomized phase 3 equivalence trial published in Lancet Oncology about a year ago. It enrolled 1,305 patients, approximately half were assigned to Elliott, half to assigned to external beam. And you saw this slide earlier. The recurrence rates at 15 years are significantly higher in the intraoperative electron therapy compared to whole breast irradiation. This is the overall survival and intention to treat. Again, no obvious change of overall survival at 15 years between the two arms. So again, the long-term results confirmed a higher rate of ipsilateral breast tumor recurrence in the Elliott group than the whole breast irradiation group, without any obvious difference in overall survival. In an unplanned analysis, they identified a group of women representing 10.8% of the entire study population at a very low risk of ipsilateral breast tumor recurrence, less than 1.3% at 10 years, in which Elliott can continue to be safely proposed. This group includes women with small, less than 1 centimeter, well-differentiated luminal A tumors with a proliferative index of Ki-67 less than 14. And in this, I just got a text saying it's showing presenter view. This is, Chirag, does it look okay, or should I change it?
I think it looks okay. You can continue with this.
All right, sounds good. And if that second bullet point was enough to be put in the last Astro partial breast radiation trial, that this was a reasonable treatment for those small tumors. IORT KV, I'll spend most of the time on this because I think this is the more controversial, interesting thing that my friend Chirag and Stephen Gromeyer and I used to do a lot, and they stopped. The rationale for KV IORT from a physics standpoint, this is just different isodose curves of 50 kV photons versus different electron energies. As you see, the dose falls off very quickly. But there is a lot of data on the radiobiological effectiveness. I remember the days where I used orthovoltage for skin cancer, and similar to this, we always gave less dose because we knew it had more of an effect. And this is an article by Frederick Wenz in 2007 showing the intrabeam from a survival fraction dose is out between MV X-rays and neutrons. So each gray is worth more. This is from another very complicated paper looking at 50 kV devices. The depth dose is specific for the X-ray spectrum and applicators. And I'll talk a little bit about that. The RBE depends upon the radiation characteristics. And in these experiments, it was between 1.1 to 2 for the physical dose at each distance from the applicator. And of course, this is just, I borrowed this from Gunnarsson and Tepper, just looking at single fractions, obviously with different alpha betas are worth more than fractionated dose. So we've got that, we've got the RBE, all suggesting that there's a sphere of equivalence, and this was published in the Red Journal in 2008, talking about you put those two together, it makes the RBE factor, makes the effective depth of curve much flatter, and targets equivalent to a full course of whole breast radiation up to a depth of about 1 centimeter. So I think the argument that the dose is low is maybe a little bit flawed. But this is what I really think is cool, and I think this is where we need to go with in radiation in general, and that's more biology. This is some translational research that was published in 2008, where Dr. Bellatiti took targeted intraoperative radiotherapy patients and collected their fluid in their lumpectomy bed for 24 hours, either if they got target or if they didn't. And you find that by giving the target, the wound fluid did not grow the cell cultures very well. suggesting maybe we're not even killing cancer with this stuff. Maybe we're just changing the milieu, killing cancer in the traditional way. This was another publication talking about how the radiotherapy induced the MAR 223 targeting the EGF pathway. So it might have some real interesting biological reasons why immediacy matters, not only from the targeting, but for this. And I'll just briefly say this is nothing against the other form of 50 kV, which is the Zoft, but they're not equivalent treatments. They have different spectrums. These are the two different 50 kV devices. They have unique depth dose, unique dose rates, unique depth dose curve, unique energy spectrum, and a unique radiobiological effect. For the intrabeam, it's about 5 gray a centimeter, just what Dr. Shah talked about. Treatment time anywhere from 20 to 45 minutes. Zoft gives it quicker with a higher dose of depth. The radiobiology between these two might not be quite the same. And I know that the intrabeam device can kick up the treatment time and make it quicker, but it would change the biology. So shouldn't do that if we're trying to use the trials that have used it. And this is the intrabeam device for those of you that haven't seen it. It is a miniature linear accelerator. The radiation comes out of this ball. It's a mobile radiation therapy platform based on low energy X-rays. I won't say for this crowd, but I use it just as much in other disease sites with different applicators than I do in breast. We talked a little bit about this. These are soft X-rays. They have quick attenuation. There are different sizes for these applicators. So really, when this started, target was a boost. You know, the first uses of it was to use it as a boost. In my last institution, we had an intrabeam device was primarily for pediatric brain tumors. We didn't use it in anything else. So this isn't just necessarily a breast machine. This is I won't go into too much detail, but this is some of the early safety and toxicity data using 20 gray of target, the service plus initial 46 gray of external beam radiation. It still seemed like this was relatively safe with good and excellent cosmesis. And especially if you waited 4 weeks of the external beam, there was no amount of fibrosis noted in these safety and toxicity data. As discussed by Dr. Shah, doing this as a boost makes a lot of sense. This is a phase 2 data that was published over a decade ago, looking at long-term results of target boost during breast conserving therapy. Their 5-year local recurrence rate in this population was 1.73%. Theoretically, it was about half of what they expected, and that led to, as we've discussed, Target B, which is a randomized trial going on now. The eligibility is either women under 45 or over 45 with some poor prognostic factors. It's trying to detect a difference between 5.6 and 2.9% with about 1,800 patients planned, and we'll have some information when that's done. What I'm going to spend a fair amount of time talking about again is Target A. You've heard a little bit about it. And I won't go into the controversies of the pre-pathology or post-pathology. I think that the 2,298 patients were evenly distributed between the pre-pathology, and I won't go into the argument of whether you need to combine the two. But there was 32 centers from 10 countries involved in this trial. So it was a fairly robust group of patients around the world. The eligibility for the trial was 45 years and older, unifocal invasive ductal carcinoma less than 3.5 centimeters. And this is where it is the supplemental external beam radiation was a little looser. If you had a surprise invasive lobular, you were to give external beam. If you have extensive intraductal component, you were to give external beam. But every center could decide on other reasons to give external beam. Grade 3, lymph node involvement, LVSI, ER negativity, whatever you thought was a high risk. If margins, it was to re-excise and give external beam radiation. Some of the early publications of the complications, especially around the surgery, looked at hematoma, infections. They seem to be fairly similar. Seromas requiring more than 3 aspirations were a little bit higher in the target group compared to the external beam radiation group. Wound breakdown was about the same, 2.8 versus 1.9%. Toxicity was a little bit higher in the external beam radiation arm, and basically they were fairly similar and fairly safe treatments. But this is what the 2 long-term mature outcomes came out recently of that pre-pathology stratum. One came out in British Medical Journal in August of 2020 and the British Journal of Cancer in 2021, looking at different aspects of the Target A randomized clinical trial. The Target post-pathology was published in JAMA Oncology about a year ago. This is some of the follow-up, and this is a very busy slide, but this is target A with immediate target IORT, just suggesting that at least at this report, as opposed to some previous reports where Dr. Shaw mentioned where they publish it a little early in the follow-up, the follow-up's fairly significant now with a fair amount of patients out 9 to 12 years. And compared to other partial breast radiation trials, it seems very similar, if not better. The study design, this was not really IORT versus non-IORT, as we talked about. It's a risk stratified design. Again, target A was breast conserving therapy and IORT, or breast conserving therapy, IORT, and further external beam radiation, anywhere from this quote unquote previous standard to hypofrac over 3 weeks. It was a fairly good risk group, but not incredibly good risk. 67% of the patients were screen detected, 84% less than 2 centimeters, only about 20% grade 3 or node positive. There were 1,140 patients assigned to IORT and 1,158 patients assigned to external beam radiation arm. As we've discussed, 20% of those patients did get supplemental external beam radiation for the reasons we discussed previously. This was the primary outcome. That was 5-year local tumor recurrence. The non-inferiority before the trial was started was 2.5% in the pre-pathology arm. The difference was 2.11 versus 0.95 within the non-inferiority stratum for the trial. This is the local recurrence-free survival and overall survival between the 2 arms. Again, statistically, is essentially the same, a little bit almost overlapping on local recurrence-free survival, a little bit better on overall survival for the target group. Breast cancer specific survival, again, similar, and non-breast cancer specific survival was the only thing that was significant, and it favored the target group. The target patients had a significantly better non-breast cancer survival. I will admit that's hard to explain. It may simply be a statistical fluke, but it is what it is. These are some more of the study things talking about breast cancer mortality, non-breast cancer mortality, and overall mortality. Again, breast cancer mortality was the same out to 12 years. Non-breast cancer mortality was much higher for the external beam arm, almost 10% versus 5%. And then the overall mortality was a little bit better for, I think this is reversed, it's about the same. So these are some of the events. We talked a little bit about that. The local recurrences were 35 in the whole cohort, 24 in the target arm, and 11 in the external beam radiation arm, about twice as much. The deaths were, again, we talked a little bit about that. I won't go through that. There was a 2 times greater cardiovascular death. It's hard to explain that with a relatively short period of time from the treatment, but it is what it is. These are some of the other articles talking about cosmesis, suggesting maybe a little bit better with IORT, but pretty similar. I think this is something we don't talk about in those of us that treat a lot of breast cancer patients. Well, most breast cancer patients, not most, but a lot of breast cancer patients that get external beam radiation always complain of a little bit of pain in the breast, especially if you push on it. So general pain, breast symptoms, and arm symptoms were all better in the target IORT group compared to the external beam radiation group. This is just, I won't go into this. This is something that gets debated a lot. And Dr. Shaw mentioned this. People have looked at this different ways. This is from the group over in the UK. Dr. Alvarado has published that he thinks the costs are better. I won't go into that. It's certainly not probably much more expensive, or even more expensive if you include all the theoretical local recurrence rates. This is some of the follow-up. So this was supervised at National Institute for Health Research from the UK. As far as completeness of follow-up, it's pretty good compared to some of the APBI trials. Follow-up time is pretty good, and the sample size is pretty good. So it's a robust, whatever you think of the trial, it is a robust sample of these patients. But if you look at some of the retrospective trials, and I will say that we talked about Dr. Valente's Target R trial. I was a co-author on both these trials, and I think the data was very honest. It was published twice. It was published in 2016 with a full 822 patients with a median follow-up of 23.3 months, with 2.3% ipsilateral breast tumor recurrence, about 17% getting whole breast radiation. And we all know that the pitfalls and pluses of multi-center retrospective trials. When it was updated with about 150 less patients because not every center gave their patient data back. I'm always think, do you think that if you were, think that could put some bias into it? Probably. For retrospective trials should always be hypothesis generating, not what you would do. It did have a 5-year 6.6% ipsilateral breast tumor recurrence, again, the same 17% whole breast radiation. But is it just that we don't do it very well in the US? If you look at a fresh multi-center retrospective trial that was published in 2020 with 676 patients, 54-month median follow-up, they had a 5-year local recurrence rate of 1.7%, a pretty high whole breast radiation arm of 31%. Chinese single center study did IORT versus ipsilateral breast tumor recurrence and had a 5-year local recurrence rate about the same between the two at about 3%. So there are some conflicting retrospective data that are out there. This is some prospective IORT studies, which we talked this to death. I won't go talking more about this. Guillaume did a single center French study of 191 patients, 40-month follow-up, an ipsilateral breast tumor recurrence rate of 1.7%. Again, another French study, 53.4 months with 200 patients, a 2.5% median, 2.5 instead of the median follow-up of 53 months. Target elderly trial that was published in the Red Journal as an abstract, 474 patients, 36 months, 5-year estimated 1.5%. Recurrence rate was 0.8% at the 36-month follow-up. So there are some prospective data suggesting that the recurrence rates are relatively similar. And it isn't like this isn't done very much. There's 260 centers in 38 countries that are actively delivering target, very concentrated in Europe, but around the whole world. And there's been about 45,000 patients so far that have been treated in 38 countries in 260 centers with target. And I will say, I didn't talk too much about this, but for those of us that treat a lot of patients that have some other challenges, it really is a good option when it's going to be hard to even get patients back for another day treatment. So my daughter may or may not be on this thing because she's a radiation oncology resident. This is how I used to look before I started debating Dr. Shah. Notice there's very little gray hair, and I look very young. Now I'm debating Dr. Shah, and look what happens. We were able to get funding for what was called a Target US phase 4 registry trial. Because again, we were trying to get some real prospective, real world data. Myself and Libby Harris were the radiation oncologists, Dennis Hose, Michael Alvarado, and Stephen Grobier, who we talked about before, were the surgeons on this study. So again, it was a prospective trial with very similar eligibility to Target A. We accrued 696 patients from May 18th, 2012 to September 15th, 2017. And I submitted an abstract to Astro, and we'll see if it gets accepted. And I can't say the data now. Also, as in any technique, and I think this is incredibly important, it's subject to how good you do it. So making sure you're doing it in a well fashion compared to your peers. A couple of centers that have very high recurrence rates that might not be doing the technique very well can very much skew the data. So we started something called a Target Collaborative Group. It doesn't have anything to do with Zeiss, more to kind of advocate for this form of therapy. And we have a quality collaborative committee, which is to improve the quality and safety of care of patients treated with breast conserving surgery and targeted IORT. The QSA is open and everyone's eligible to put their patients on it. It will enable longitudinal outcome analysis, reporting, and publications, establish best practices, decision support and care pathways that enhance patient care and safety, and enable transition to share accountability care payment models. The QC also meets the ASTRO criteria related to low-dose IORT as the treatment of breast cancer being on a registry trial or a registry. And we've been pretty successful putting patients on there. Future directions. So I think I convinced you that this is the best form of therapy since sliced bread, but future directions, I think this is really cool. We are trying to get this open at our place. This is being done by Eileen Conley at Columbia. And it's basically a trial where we're going to be she's giving Pembro twice doing a lumpectomy, sentinel lymph node, and giving IORT and looking at the aposcopal and some post-op blood and wound fluid and different things to see if they could see if this really has an effect. These are some of the cool things I could think you could do with IORT that you can't do with treatment after the lumpectomy. So in conclusion, I think the long-term outcomes of the Elliott trial reveal significant increase in local recurrence, similar survival, and a good subgroup, and in a good risk subgroup of small local recurrence rate. Target A long-term follow-up notes no difference in local recurrence-free survival. Again, that is local recurrence-free survival, which is different than ipsilateral breast tumor recurrence. I will agree with that. Similar overall survival and improved non-breast cancer death. The majority of retrospective trials have noted similar outcomes, and target US abstracts has been submitted to ASTRO, and we'll see what a prospective group of physicians in the US gave for local recurrence rates. And I finished right on 20 minutes. Well, thank you very much.
Thank you so much, Dr. Small. We have a couple questions in the chat, and for anyone else who has a question, please feel free to submit it to the chat. Our first question is from Dr. Wazer, who says, can you comment on patient selection and use of hormonal therapy in Target A? How does the Target A results compare to no radiotherapy studies?
Go ahead, you go first.
Go ahead, Dr. Small, please.
No, go ahead, you go first.
It's actually funny. I had to pull it up. So it's actually not in the 2014 or 2020 papers, but it is in the 2010 papers. So the risk group is a little bit higher risk than Prime 2 or CALGB. Only about 40% of patients in both arms of the trial were over the age of 65. In terms of with respect to nodes, about 22% of patients, or 20 or so percent of patients, were node positive. So obviously higher than CALGB or Prime 2. And there were about 10% in both arms that were ER negative. In terms of endocrine therapy received, about 65% received endocrine therapy. So I would say based on that, a little bit higher risk than Prime 2 or a CALGB 93-43, but more in line with import low, B39, and rapid. Dr. Small, anything you would add to that?
I was going to say there is a publication that the Target A group went through and tried to go through with their high-risk patients between the external beam and intraop, and they seem similar. I think that's something that comes up a lot, Dave. I do think that since there was 20% node positive, 20% grade 3, not necessarily tiny tumors, that I do think there is a benefit. I think people will say you're treating patients that don't need radiation, so it's not doing anything, but I don't really think that's fair given it's not necessarily that low of a risk group.
Next question, Dr. Small, I'll let you take this one. Can you comment on IORT for DCIS?
I do it. I must admit, I do it when it's somebody that I might feel comfortable not treating at all. There's some limited data. I don't think it's by anywhere a standard of care. I know there's been some pushes to try to get some larger trials done. I don't do it in anyone that personally, my own thing, I don't do it in anyone that I really feel that really needs radiation. So I'll do it in some low-grade DCIS patients and elderly patients for some treatment.
Yeah, I would agree. I mean, I think it's tricky. It's the same thing as other partial breast techniques in DCIS. They were excluded from some tech trials. They were included in small numbers in other trials. So we don't have great data. I mean, I think the largest APBI other than IORT DCIS upset's only 300 or 400 patients. The one concern I've always had is actually Dennis Holm published his experience on DCIS and IORT, and the rates of recurrence were a little bit higher than you would expect overall. I think they were around 5 or 6% with short follow-up. So I agree with Dr. Small. If you're going to do it on very low risk patients. In terms, and I guess the question is, are you getting insurance approval for those DCIS patients, Dr. Small?
I in this day and age, we don't treat anybody if we don't get insurance approval. So yes, I did. At times it's a fight. I would agree with that. I think that it's, ever since some certain guidelines came out, it became a little bit more of a fight, but I usually can get through by just showing the data and saying, there's a significant, we've done things. I was back when we started Mammocyte based on very little data. This at least has some data. So I usually can get it approved, but it's a fight sometimes.
Yeah, and I think Dr. Fox had asked about, getting insurance approval in general. I mean, I struggle with it when I use it for Boost. To be honest, I like to use it in, say, a 39-year-old triple negative patient who's going to get a lumpectomy with oncoplastic surgery or won't see the cavity. I've struggled to get it, but I will try to advocate it. There's actually very good long-term follow-up data on IORT Boost, irrespective of oncoplastic surgery. So I've used it in those cases and that's worked. I think as monotherapy, it's going to be challenging given the electron data as well as some of the target concerns, and it may be harder to get that approval unless there's more data presented to help kind of sway things, I think, a bit. Next question is from Dr. Anderson in Wisconsin. Are there some more common QA pitfalls of IORT do you recommend looking out for? Dr. Small,
I think personally, I think that it's really very surgeon dependent. I think that if you're going to do this, you better make sure that the applicator is the right size, that it's conforming to the breast tissue as accurately as possible, that you do a suture to keep things in place. I always do an ultrasound to look not only for distance from the skin, but also for fluid or air gaps, meaning we're not touching the breast very well around the applicator. So I think the machine works pretty well. I don't think there's much problems with the machine delivering the radiation we think it's delivering. I think it's really a surgery dependent technique that's the thing I worry about the most. I don't know about what you say, Dr. Shah.
Yeah, I've done a couple hundred target cases with Dr. Gromeyer over the past few years, and I guess what I would say is a couple things. One, you really want expertise in placing the applicator and placing it and then suturing it in place. And so I think that's where having some guidance and expertise is important in terms of approximating the incision when you place the applicator in. I also completely agree. We really do use an ultrasound to make sure the skin distance is more than 1 centimeter so that we're not getting really high doses at the skin. The other thing that we use at the clinic, which is we actually don't often use the stand that comes with Target. We actually created a little C-arm that we just connect in, and it makes it much easier to use the applicator when needed. And sizing is really important. You don't want to be too small because then you're basically treating air. And one of the challenges is that sometimes it's counterintuitive, but like the smaller applicators mean you have a shorter time, but you want to make sure you really get that applicator touching all the surfaces and making sure that it's stitched in. And then the last thing we do, and I'm not sure how much data there is around this, we actually place little pieces of lead sheets in plastic bags, and we actually place them around with clamps all the way around the incision area and the skin as well.
Yeah, we do the same thing. And I think that if there's one argument I have in surgeons that haven't done a lot of this, is I ask them to get a bigger sphere. If they're between two sizes, let's use a bigger one.
Yeah.
Even though if you do this and you put a 5 centimeter cylinder in, you're there for a little bit longer. It is the right thing to do, I think.
Yeah. Yeah. And for those radiation oncologists on the phone, if you use a 5.0 centimeter, just have some completion notes to finish while you're waiting.
And another question about DCIs. Yes, I have. Again, I've had good luck and I've argued my way through. There's only been a couple people I haven't been able to argue through, and it's hard to go too hard against the reviewers because there are, as we all know, there's plenty of other options out there. So if they don't get approval, we pivot.
Yeah, and this is, I think, a good question to segue to. This was, can we expect the ASTRO and ABS guidelines to include IORT as an acceptable form of APBI in the near future? I'll give my 2 cents. Obviously I don't speak for either committee, but my take is it's probably going to be challenging. And with the electron data, I think that's very hard to say it's an acceptable form of IORT given the Elliott trial as well as the subsequent paper comparing it. Granted, that was a non-prospective study comparing it to other forms of PBI. With regards to target, it's really how you interpret the data. I think, if you look at and exclude the post-path group, exclude the concerns that have been raised, you look at just the pre-path group, is that a pathway to considering it? I'm not certain. I still have concerns about the pre-path group given the 60 versus 24 local recurrences that, somewhere between 10 and 15 years. I think that's going to be an area of continued debate, to be honest.
And I find this debate kind of interesting. We published a paper in Women Over 70 where we didn't give radiation with a fairly big difference in local recurrence and thought that was a reasonable option if women chose that. So I'm not sure why when the survival and the disease-free survival is similar out to 12 years, we have this debate that much. I do talk to patients, and my consents say some of Dr. Shah's data that this recurrence rate, I think, could be higher at 10 years than we predict, but there's pretty good data that the survival would be the same, and you will be done when you wake up. And for our patients that travel a long ways in, for our patients that have a very hard time, even with one trip in from getting funding to come there or getting off work or getting off things, this is a really nice tool to have. I just use it on a very select group of patients. It's not my primary treatment for breast cancer. It is a group, though, I think that it really offers one of those tools. I also do hyperthermia. I also, have done other forms of brachytherapy. I think that this is a tool you want to have in your tool bag when you're talking to a patient about all the different options. Breast cancer used to be easy. 6 weeks of radiation, whole breast, and that was it. Now we made it very hard and very complicated, but I think it's a very nice option to have in your tool bag.
Yeah, no, I agree. I like I said, I use it in the right situation, and I think that's the challenge. I mean, I'm looking forward to Target E being published with more long-term follow-up, because I think that will answer that question to some degree. Is in that really low-risk group where we're thinking about omitting radiation. And the other thing that I'll bring up is that I'm seeing more and more patients who don't want to take endocrine therapy,
Right.
which kind of negates the prime 2C LGB and is some kind of de minimis radiation strategy, whether that be IORT or 5-fraction, whatever it may be, a better option than no treatment altogether. I would argue it is. I think that's what B21 taught me, which is that any form of radiation is better than endocrine therapy alone with respect to local control without compromising distant metastases, which is often an argument for using endocrine therapy irrespective of overall risk. So I think that's going to be an evolving target. The Europa trial is looking at that, endocrine therapy alone versus radiation alone in the modern setting. So I think that'll be helpful to also for these low risk patients to think about.
Yeah, no, I treat a fair amount of patients over 70 because it seems like no one takes their hormones for 5 years off study. So it gives them a little bit of treatment, a good treatment, whether they take the hormones or not.
Perfect. I don't see any other questions, so I think this is a good place to wrap things up. I want to thank Dr. Small for being my counterfoil on this, and as always, I think he's beaten me into submission. So thank you, Dr. Small, for taking the time to speak today with me.
No, thanks for inviting me, and I really appreciate it. And everyone have a great weekend. If it's holiday for you, have a great holiday.
Yep. And just as a reminder, the next webinar will be an Yttrium 90 webinar from the ABS. Also, conference registration for the annual meeting will start next week. Thank you, everyone, and have a good evening.
Thanks, guys. Bye-bye.